Why prone a patient? So you've all understood the pathophysiology of ARDS really well with Dr. Raymond's talk. So I'm just going to go over the proning aspect of it. Now, if you look at it, what is functional residual capacity? It is the volume of the gas in the lung after an exhalation. Now, when a patient is supine, if you look at this, I think you will understand better. When a patient, the above two pictures are for the supine, normal and ARDS lung, and the bottom two are for prone lungs. Now, if you can look at the top right, a supine patient with an ARDS lung has a large lower part, which is the dorsal lung, which is atelectatic, fluid filled. The middle, which is the the lung which is getting the optimal ventilation, and the above is the hyperinflated lung. Now, if you see the lung volume, the hyperinflated lung and the lung receiving optimal ventilation are all smaller in volume as compared to the dorsal component of the lung. If you look below, look at the prone lung. Now, in the prone lung, the larger volume of the lung is the lung which is well inflated, which has good ventilation. There is still the small belt of hyperinflated lung. Now, besides all this, the other things that proning contributes to. Now, the heart in a supine patient because of gravity, it is compressing upon the lung. So, as a result of which, the left lung is compressed because of the pressure of the heart. The moment you prone the patient, what happens is this gravitational effect of the heart gets eliminated. The heart is now resting against the rib cage, allowing room for the lung to expand. Besides this is the diaphragm. Now, what also happens is when a patient lies supine, the pressure of the abdominal contents pushes the diaphragm, again further compressing the lung, preventing its free expansion. A prone patient, especially with a free abdomen, eliminates this pressure of the abdominal contents through the diaphragm. So if you can see, the lung inflation is homogeneous. These are CT scans of patients. The above is that of a supine patient. The other one is an ARDS lung prone. As you can see, the dorsal lung has opened up in the prone position, and the volume of the collapsed lung is lower. So what are we all looking at as of now? The lung inflation becomes more homogeneous. The area of over-distended alveoli, that is the volume of over-distended alveoli, has reduced. Recruitment is better. The previously degassed dorsal lung has now fully opened. Yes, there is an element of atelectatic lung now, which is now the ventral component, but this is a smaller volume of the lung. Apart from this, there is the element of an improvement in the ventilation perfusion. How does ventilation perfusion change? Now, if you look at this image, the first, the top image is of a supine patient and the lower one is of a prone patient. In the supine position, the ventral lung is the lung which has got good ventilation. It is the lung which has the lowest perfusion. Please see the top right. There is a section for the blood flow. Now, if you see, the blood flow actually doesn't change whether the patient is supine or prone. The perfusion remains the same. The dorsal lung gets the larger component of the blood flow. The blood flow decreases as you go ventral. But the difference is, in the supine position, the dorsal part of the lung, which also has more blood flow, is actually having less ventilation. The ventral part of the lung, which has less blood flow, has more ventilation. Now, this ratio gets completely reversed the moment you prone the patient. So the dorsal lung, which is now well inflated, is also the part of the lung which has a better perfusion. Now, from the COVID perspective, there are two pathophysiologies that are, being studied right now. One is that, if it is a typical ARDS lung, fluid-filled collapsed alveoli, then of course proning helps because it helps in improving secretion, improving clearance of secretions. There is the alveoli open up, hyperinflation reduces, ventilator-induced lung injury reduces. The other aspect is the aspect where maybe what COVID actually causes is multiple small emboli. If it is because of multiple small emboli, then basically what is happening is the perfusion is reducing. In a state of reduced perfusion, Proning may help because the areas of the lung receiving perfusion may be better ventilated because you're increasing the volume of the lung that is open and ventilated. Now that we understand why we want to prone a patient, so these are the benefits. I've just gone through them. Oxygenation improves because of a multitude of factors. Ventilation perfusion matching has improved. Patient in the prone position. This is very important to understand. Prone position helps to clear secretions. And in fact, the moment you prone the patient from the supine, there is often a flood of secretions that comes out. And from the COVID perspective, this is a huge scope for aerosolization. I will go into this later. Recruitment maneuvers are more effective. Why? Because again, more alveoli which are there to get recruited. And the recruitment maneuvers are effective for a longer period of time because these alveoli stay open for longer periods. If alveoli are open, the aerosolized medicines will be delivered better. So the effect of aerosolized medicines are better. There is also decreased ventilator-induced lung injury, which I've already gone over. There is lesser area of hyperinflated lung. So there is a decreased VILI that occurs.